session, a dialogue that brings global expertise to the forefront of healthcare quality. This session will highlight on how quality and patient safety transcend borders, uniting healthcare professionals across the world. ISQua represents the gold standard in healthcare quality worldwide, shaping policies, strengthening systems, and inspiring trust across borders. We are privileged to be a part of this global conversation today.
It's an honor to introduce our moderator, Dr. Brennan, General Practitioner from Ireland and Board Member ISQua. We are also privileged to have an esteemed international panel, Dr. Ezequiel, García, Director, Institute of Clinical Effectiveness and Health Policy, Argentina, and President and Board Member, ISQua. It's also an honor and privilege to welcome Dr. David Bates, Chief Division of General Medicine, Birmingham and Women's Hospital, USA, and ISQua Academy member, and our always shining and eminent CAHO GC member, Dr. Anuradha Pichumani, Executive Director, Sree Renga Hospital, Tamil Nadu, and a board member of ISQua.
We now invite our moderator and panelists to begin this insightful dialogue. Over to you.
Van Khan Chennai. I've been working with my language coach all morning on that one. It is a pleasure to be here, and as we've been hearing already this morning, for us to share a dialogue together, I think it's important that we have two things. The first is a language that we can share, and I know that this is a nation of many different languages. Tamil, I learned yesterday, is one of the most ancient languages in the world. So it is an honor to be able to try to learn some of that with you and with Dr. Anu. I think in this session, though, the language I hope that we will share is the language of quality and patient safety, which is a global language. And in this dialogue, we hope that we will connect India with the rest of the world when it comes to the perspectives that we take on the challenges that we face. The second thing I think we need for a meaningful dialogue is some connection. And since arriving in Chennai as an Irishman, I have been learning about a wonderful lady called Annie Besant. People familiar with Annie Besant? So in Chennai, I think particularly, she is known as having been a force for good in education, in women's rights, and as the first female president of the Indian National Congress. Did you know, though, that Annie Besant came from Irish heritage? She had an Irish mother and a father who trained as a physician in Trinity College in Dublin. So if we gave you Annie Besant from Dublin, where ISQua is headquartered, we are delighted, I suppose, to be here as ISQua for you to give us the perspectives that we need to take back to other parts of the world from India. So I look forward to our dialogue together through our shared language and our mutual connection. Let's begin, maybe Dr. Anu, with you, a local in this area, or relatively so, so that we can take things from the global to the local, where healthcare happens, where the rubber meets the road, as we say. What are the quality and safety challenges that you worry most about in your hospital today?
So good morning to all of you, and thank you, John, for that question. I think we can answer this question in two levels. The safety and quality challenges which is happening in most parts of the world, and especially in India, and the challenges and what are the issues which we face and what can be done about it. So the challenge basically for the physician's perspective is more on the communication issues which we see where the communication can be either the handovers between doctors or between the healthcare professionals and the patients. It happens at various levels, and again there are so much of insufficient communication which happens and creates harm to the patients. And again, the second challenge is what we know as policy and what is being done at the ground level. So all of us have protocols and checklists and everything, but whether it is being translated at the ground level, whether it's being done, that is a huge challenge for any hospital owner to move on. And again, we have the challenge of, especially in India, with huge numbers of patients. We have the stress and burnout happening. And whenever you have a huge workload, the safety takes a backseat. Sometimes you miss out on doing some safety checklist. And on the patient's perspective, again, to voice their own concern is an issue, because we have, this country is a huge, diverse country with various languages and various levels of literacy. And so again, we have a challenge of getting the patient's voice on board. But the underlying thing of all these challenges is getting the safety culture right. So when you have the safety culture, even if you have a checklist and other things, if you have the safety culture right, everything happens fine. And so we have these programs from CAHO as well as from ISQua. We are talking about safety culture across the globe, and we need to get our systems right, where we are able to shift from a blaming culture to a learning culture, to move it from hierarchy to having it as a teamwork, and again moving from a provider system to a partnership-driven system. And again, just not doing it as a compliance, but understanding the context and then doing it for patient safety. These are some of the ways where we can meet these challenges, and I hope we do all of them together. Thank you.
Thank you, Dr. Anu. And I would say, I mean, these problems are not, unique to India, right? These are problems that healthcare systems all over the world have. And David, you've been working in kind of healthcare quality and patient safety for some time now, both nationally in the US and internationally. What are your perspectives on these problems? They're not new. How should we be thinking about them or approaching them differently?
Yeah, well, I think we understand a lot more about what the quality and safety issues are now than we did, say, 15 or 20 years ago, when people were still dealing with the idea that, asking the question, are safety and quality important? I have to say, I'm frustrated with our lack of progress. We have gotten somewhat better in some areas, but there are lots of other areas. Which we're not making as much of a difference. I think, though, today with the use of artificial intelligence and other approaches, we have the opportunity to do some things that are really transformational, and that's what I'm excited about.
And on that point of artificial intelligence, as maybe being one of the global opportunities, but also one of the global challenges we will need to kind of face together. There is a lot of hype, a lot of energy, in that space. What are the types of challenges we need to think about in harnessing that energy for best effect? How should leaders be thinking about integrating artificial intelligence and making sure we do that to get the maximum benefit?
I think one of the biggest things that organizations face is trying to decide which things to do first. The things that really work the best are reading of images. AI is unbelievably good at that. It does it much faster, much better, more accuracy. And we have also had really good experiences with ambient documentation, with having the AI generate notes. And that saves clinicians a lot of time. I think that's one of the technologies that will be very useful here in India because of the shortness of your consultations. An average consultation of 2 to 5 minutes. You just have to be very quick.
Okay, and then Ezequiel, as a researcher, as an improvement and implementation scientist, artificial intelligence is not the first tool of improvement, that we've seen over the last 30 years that shows lots of promise, right? We've had electronic healthcare records, we've had checklists and care bundles and different tools and innovations that have come along the way with tons of promise that maybe haven't delivered at the level we would have hoped for quality and safety. So why is that, and what do we need to be thinking about to give it the best chance to help us?
Well, thanks for the question. I have the sense that complex problems do not have simple solutions. And sometimes we are eager to find low-hanging fruits that hopefully solves problems of health systems. So that's why we failed in understanding in the past, trying to apply, I would say, hastily solutions that maybe require either adaptation, either maybe understanding what would be the best use of them, as David said, for example, for AI. So I hope that, first AI is a real solution for healthcare problems. Because in the past we thought that some others provide, I would say, whole system solutions, and they don't. So first we need to be careful on, David said again, what AI can do best presently. Then we'll need to, I would say, invest in trying to, for those solutions, not to provide, to enlarge equity gap, in terms that only a few of health systems or patients or providers have excel at their use and others will not get benefit of that. So that will reduce the equity gap. And for that we need some research. And I have a sense that maybe we do not have that much time to wait for in terms of having solutions presently. But we need to either devote time in developing the research to understand which way we should go, or at least have some data collection and help us understand where these solutions are most helpful. But as we all know, this is not a great time for research because not much funding is going to this. So my biggest concern is that since AI in general are in the hands of private equity, is that solutions go faster than understanding the needs and applications. So hopefully this is not another failure of a solution that goes wrong. So we'll see. And also the settings are different. Data settings, which data-rich settings, it's easier eventually to apply some solutions, but in others, like for example, less resource economies, like South America in general, I would say that need to be careful.
Okay, and David, back to you on that question then of equity. I mean, we've heard from the former Vice President earlier and others so far at this conference about challenges in nations around access and around cost. Is artificial intelligence, in your mind, as we're prepared to move on with it, is that something that's going to close equity gaps, do you think, or something that could potentially widen them?
It depends completely on how artificial intelligence is used. There's good evidence that it has, in some instances, actually really widened equity gaps. And so one of the most important things, if you're implementing artificial intelligence, is to be checking to make sure that that's not happening, and also to put in certain safeguards so that it doesn't happen in the first place. But I think many organizations have not figured out how to do that, or not sure about how to do it. So that's one of the things that I think we have to watch most with the implementation of artificial intelligence. There's some good tools for trying to prevent that from happening, but there have been some very well-known and described examples in the US, for example, where it was shown that it did widen equity gaps.
Great. I want to encourage all of you as well in this dialogue to maybe have your questions ready, because we hope to spend the last few minutes together and taking some of your questions. There are microphones around the room. So let's move away from technology then for a minute. I mean, some of the other challenges we face globally are around workforce shortages, ever-increasing care complexity, and then depending on the context, maybe a triple burden of disease around communicable, non-communicable diseases and trauma. I suppose there's a perspective out there as well that, quality is owned by and delivered by people, that all quality improvement in some respect is social, Dr. Anna. How do we, best kind of think about that or influence that, on the ground, do you think? What messages do you have for people here around engaging the workforce?
So thank you for that. I think this is one of the most important part of the leadership commitment. When we start out with the leader has to redesign the systems so that the workforce feels safe to speak up. So the environment has to be set right. And because you need the workforce to have a safe culture. So psychologically they have to feel safe whenever something happens. And so the leader has to create a just culture within the system. And again, make it more open so that you have people coming up with if there is any issues. So this leadership commitment does not stop with that. You have to walk the talk. So whatever you're going to do, it has to be done at the ground level. So these are some of the ways where this can be done. And when we did some of the collaborators with Harvard, these are some of the things which we also worked on, because the behavioral change of a healthcare professional is very important. So we were working on getting champions on board within the team, and we were working on getting the teams ready where we are trying to do the behavioral change, make them as leaders. Whenever you're going to start any project, involve them at the beginning itself. Don't make them as implementers. So they have to be co-creators of any project. Only then the involvement and the compliance starts improving. So the healthcare professionals have to be made understood that this is really needed, and getting them as champions will always help you to move any safety project. And from CAHO, we see all the leaders here, CAHO and ISQua, we have all your leaders who are trying to do so many things to improve the whole system. And anywhere globally, I think this leadership commitment involves getting the people on board. Thank you.
And there is a tremendous challenge, right, in trying to transfer the energy that we can share here and the connection with the teams that we lead in delivering care, right? In addition then to working with the people providing care, I suppose over the last couple of decades, the movement to make care more person-centered and to co-produce care with patients, to bring patients more into the space of designing better healthcare and better systems, and in how we integrate innovation and that type of thing has gathered pace. But I suppose COVID was a good example of an existential kind of challenge, and there are more coming, right, with climate change and conflict in different parts of the world, where suddenly person-centered care maybe is seen as a luxury that is expendable, in a way when decisions need to be made quickly or risks need to be managed efficiently. What are your perspectives on that? I mean, where is the true value in person-centered care, and how do we protect it and build on it regardless of what challenges come?
So I think person-centered care is very crucial when we are designing the systems itself. And so there is a false dichotomy that whenever there is a challenge which happens, then immediately person-centered care goes for a toss. So that should not happen, because if the leadership commitment is there, we would have redesigned the systems, and in case of emergency, it has to happen. And the trust is very essential for the patients to move on. And in India, we have families coming into the hospitals whenever the patients deliver, or there is a sick patient in the ICU. This is the way the family and community work in India, though it's becoming more nuclear in metros. But most of the villages, we have patients and the family members coming in, and they do share their perspectives in the decision making. So the challenge is getting them empowered now. So getting the patients and family members empowered and then engaging them, it's very important. And that's how we co-design process, and we are trying to get the patient and family-centered advisory councils and committees within our own organizations. And in CAHO, we have started the Patient for Patient Safety Foundation, because in India it's quite a new concept of getting the person-centered care being done at the ground level in a structured way. So we have this foundation which has been working on it, and we have brought up various new modules. You would have seen the patient-friendly standards for hospitals being released now. So similarly in ISQua, we have brought out a new module, how to run a PFCAC in your own organization. So these are some of the ways which we can learn and then start implementing in our own hospitals and do some collaborating projects, co-design some projects with the patients and family members. It's more easier to start out with chronic disease patients like dialysis patients or diabetic patients because they repeatedly visit the hospitals and they are in a better way to tell us what to change, and including their perspectives, we are able to redesign the process or redesign even the infrastructure. So in that way, the person-centered care has to happen at the ground level.
Fantastic. So, I mean, it sounds very Donabedian-esque to me. We need the structures, processes, and the culture to give us those person-centered outcomes. And of course, Donabedian also told us that the secret to quality is love, right? And I know that shared love for several of us on this panel is primary care and the role that it can play in health systems, again, to help with access, to reduce cost, and to improve equity. And Ezequiel, I want to come to you on that question of primary care. Where are we worldwide on primary care in terms of, you know, priority, impact, and what's coming next?
The problem is not that I can give you a definite answer, but first we need to remind us that healthcare is part of the social demand that people has on the system. And as the Prime Minister, the Vice President said, whatever, he talked about access all the time, because that's the demand of the society. So the thing is, how we can satisfy access in a way that it's something that solves problems. Because for the moment, we're satisfying neither of them. Because eventually, we can say that primary care is not in the places it should be around the world for different reasons. So we keep pushing for primary care and access. But as we know, whenever someone accesses a system, it's not that we're going to solve the problems. Eventually, we're going to create more. So I would say that first, the music of primary care, it's a music that should still be played. Of course, we need to do more, we need to do better, we need to make the people understand that primary care physicians or providers in general are the right one for them whenever they touch the system for the first time. And also we need to remind providers that working in primary care is not a punishment. It's something that eventually in certain health systems is promoted and well paid, which is not the case usually for the most countries. So we have the issue of demand and access and meaningful access. Then we have the issue of payment systems. And then we have the issue of trying to also teach in colleges, or I would say graduate schools, nursing, medicine, or whatever profession, that primary care should compose 50% of the care of the providers, and no 10 or less percent, and it's not the first choice for most providers. So, and also regarding where we are, I believe that I don't have at the top of my mind the evidence of the final reports, but of course we are very far from where we should be. And we have examples everywhere. And again, for less resource settings, the ways that we should go to. But again, at least for my country, presently, it's very difficult to get primary care physicians to be in place. It's very difficult. And you know, politicians are very clever. Well, they keep building primary care centers. But it's very difficult for them whenever they build those centers for the public to be happy because they have care needs close by. They don't have the providers to make it their run. So it's a paradox that I don't know how we're going to solve. So it's a big issue, and hopefully we can find some solutions soon. It will be good to hear from David because, you know, he used to run a primary care division in a big teaching hospital in a country where maybe Massachusetts is better than the rest, but where primary care is not well regarded compared to specialty medicine.
David?
Sure, I would say we have a long ways to go too. I think primary care is critical. It's first, foremost, it's fundamental. That's what the National Academy report on this topic said. And if you have a primary care provider, it's been shown that you live longer, your costs are lower. So the evidence for that primary care works is actually pretty impressive. If you have more specialists in an area, there's no evidence that health is better at all, actually. Which is not to say that specialists don't do a lot of valuable things, but primary care needs more attention. In the U.S., we have a huge shortage of primary care physicians, and it's clear that we are going to have to fill that in with mid-level providers, and a lot of primary care will be delivered by them. I mean, another dynamic that's going on is that patients have access to lots more information. So they in the U.S. now mostly have personal health records, so they can see, what are their conditions, how are they doing, what is their hemoglobin A1C, if they have diabetes, are they making progress with that? And I think that availability of information and so forth, and the improved ability to engage patients is going to be a big part of what we're going to see make a difference in the next 5 to 10 years.
So a case perhaps then that one of the most valuable domains of the healthcare system is least valued.
Yeah, exactly.
So we're keen to take some questions from the floor as well. There are microphones through the middle of the room. If you have a question, please stand and come to a microphone so that we can see you. Another question I have, Ezequiel, for you is, the role of societies and groups such as CAHO here in India, which is, growing at an incredible pace and having a huge impact, and, our own ISQua, the International Society for Quality in Healthcare. When we're looking at these challenges that are shared across nations and different parts of the world, and often require multilateral responses and strategies, what role do those groups and societies play?
Well, my humble experience in ISQua, which is the society I know the most, is that there are 2 levels. One is the level of the community, where you gather people together, the grassroots movements, and I have the sense that probably for people that work in quality of care, ISQua is well recognized as a convener. But then where we fail is maybe in how we can work with decision makers, funders, or regulatory bodies in order to transform care delivery. And I have the sense that that's also the case for other societies, like WONCA or other primary care groups, because we all has aspirations of convening and transforming, but the transformation is more difficult. I don't know about specialty groups, but I'm sure that every professional society believes that they might do a good, reasonable work in convening. That's the case of CAHO, for example. But who knows how well we do in transforming. And that's difficult for many reasons that are not easy to solve.
And Dr. Anu, as a member of ISQua, a fellow and a board member, how has ISQua influenced or changed you and your work?
So I think my journey has been quite transformative. So last 34 years, the first, I think more than 20 years, I've been working locally in my own hospital as a clinician and as a laparoscopic surgeon and doing my own surgeries and running the hospital. And then I moved on to national quality work with CAHO, and that's how I started getting interested more into quality and patient safety. And then came into the ISQua board because of the various work which I have been doing with Harvard and other organizations now. So this learning has been really transformative because we have learned globally and I am trying to implement it locally. So whatever we have learned from outside. And again, doing a course in Harvard, the Global Intensive Course, Healthcare Delivery Intensive Course, it's called GHDI. It's just opened up my mind and how it works internationally. So taking up collaboratives to do it at the local level, it helped me a lot. And when we come to the values of ISQua, the values of knowledge, so the knowledge committee where we work together to get the resources right, again the various values and action where we are trying to get these white papers, trying to implement it not only in India, now across globally now. So these are some of the ways which has helped the transformation. So we need to learn globally, implement it locally, and also scale it up effectively. That's the way it goes. Thank you so much.
Fantastic. David, and then we have one question from the floor.
Yeah, I think organizations like CAHO and ISQua are critically important in quality and safety because they can help you figure out which things you should try first, what's actually going to work for you. That in my mind, is their sort of base contribution.
Great. We have a question from the floor as well. I would ask that you introduce yourself, please, and let us know who your question is addressed to.
Good afternoon, I am Dr. Ravi, I am the President-elect of IECS Tamil Nadu. The basic ISQua is for quality and safety. My basic question is, small, medium hospitals where there are resource constraints, how to implement, do you have any special programs or some norms that can fit in and train small, medium hospitals where the resource is the major constraint, and economically it may not be feasible in many of the hospitals, but they want to give the quality health care, but the constraints are economic burden. So ISQua, does it have any program for that?
Thank you. So, I mean, your question kind of, transcends our discussion, right? Getting from global to local in context for action. And Dr. Annie, you may be best placed to answer that question in terms of, how ISQua has worked for you and your hospital, which again is a smaller, medium-sized hospital.
Yeah, so from ISQua, ISQua is the organization which sets standards across the world and gets the accredited bodies right. So through NABH, we have the NABH being accredited by ISQua, and that's how all the hospitals have started moving into these accreditation standards. And since it was quite difficult for smaller hospitals to take it up, NABH then opened up entry-level standards. So we call it as entry-level standards, so that small and medium hospitals can take it up. But again, quality always comes with a cost, and it is difficult, as you all understand. That is a challenge. But we need to work through the challenge because we need to get the quality right to our own patients. So that's how many of our hospitals have been quality driven, and we have been doing it still, in spite of all these challenges. Thank you.
And I'm going to add that probably ISQua or neither society is the solutions. It's a members of society, so people contribute individually, and also institutions like your own accreditation body is part of ISQua. Is trying to provide solutions locally. But as David said, it's a place where to look for and maybe to suggest which way to go. But be in touch, because you're not the only one, or you do not represent the only people that has the same issues. Other countries face similar issues, so maybe you can learn from those too.
And I would just say very briefly that small and medium-sized hospitals actually have the most room for improvement typically. And if you improve your quality and improve your safety, you actually will save money. So you could benefit the most.
I'm keen to close. We've heard the buzzer, but I am keen to close with maybe a short message of hope. One or two sentences. David?
Sure. I'm especially excited about using artificial intelligence to go through electronic health records to look for safety issues. We think we can find most of them today. And that would let organizations know how safe their care is and give us a blueprint for how to improve it.
Ezequiel?
Let's not give up. We need to do a lot more. There are solutions there that are available that we haven't yet used. So it's not, the issue is not what we don't know, it's that what we know and we haven't done yet. So there's a lot of room for improvement over there.
And Dr. Annie?
So we all know quality and safety is the foundation for any of our healthcare organization. And specifically when it's being taken up with the help of technology, we try to improve on patient safety and quality. And that has to be embedded with person-centered care. These are two things which will help us in the future to move our own hospitals safer care. Thank you.
And my hope rests in all of you and all of the great work that you do every day. So thank you very much, not just for being here and for your engagement, but for all of the quality and safety that you all deliver all of the time to your patients. Thank you.
Request all our esteemed chairperson and speakers to please come on the left side of the stage for a photograph. So thank you for your esteemed panel discussion and for sharing such a powerful global perspective. Today's discussion reminds us that while healthcare system may differ, the commitment to quality, patient safety, and trust remains universal. So I think this is the key home message that we all should take with this. And it is through these conversations we continue to learn, evolve, and